triple antiplatelet therapy reduces the occurrence of post-operative major adverse cardiac events. Acute myocardial infarction is caused by the occlusion of blood vessel lumens due to injured vascular endothelium and unstable plaque rupture, along with platelet activation, aggregation, and adhesion. Restoration of the infracted blood vessels and prevention of further complications are the main goal of treatment. One such effective treatment method is percutaneous coronary intervention. But this method has a potential to increase the risk of major adverse cardiac events. The risk rate is higher in diabetic patients. Dual and triple antiplatelet therapy with aspirin and other anticoagulants, such as clopidogrel, prasugrel, and ticagrelor, decreases the occurrence of slow flow, no reflow, and instant thrombosis. The aim of the study was to evaluate the efficacy and safety of dual and triple antiplatelet therapy in patients with diabetes and acute ST segment elevation myocardial infarction who had undergone primary percutaneous coronary intervention. It was a phase 4, single-center, randomized, double-blind, placebo-controlled study. The study included 258 patients. In Group A, there were 85 patients. In Group B, there were 87 patients. And, in Group C, there were 86 patients. The inclusion criteria for patients was as follows. Admission within 12 hours from the onset of ST segment elevation myocardial infarction. Patients with diabetes. Consent to the implementation of primary percutaneous coronary intervention. No previous thrombolytic therapy. Exclusion criteria is as follows. Onset of ST-EMI longer than 12 hours before admission. History of aortic dissection. Presence of severe hypertension. Systolic blood pressure greater than 180 mm of mercury and or diastolic blood pressure greater than 110 mm of mercury. Previous post-thrombolysis from medial PCI. History of any cardiac disorders, cerebrovascular disorders, or severe physical trauma within the last 30 days. Severe liver and kidney dysfunction. Presence of active internal bleeding or a history of bleeding within 30 days. Acute myocardial infarction combined with cardiogenic shock or severe left ventricular dysfunction. Acute myocardial infarction combined with acute pericarditis. The patients were randomized to receive 3 different drug regimens. The patients in Group A received aspirin and clopidogrel. Group B received aspirin, clopidogrel, and tirofiban. And Group C received aspirin, ticagrelor, and tirofiban. The efficacy endpoint was short-term complications, and safety endpoint was bleeding. Average hospital stay for Groups B and C was shorter than Group A. There were 2 events of instant thrombosis in Group A, while there were no such events in Groups B and C. 21 cases of severe arrhythmias were observed in Group A, 11 in Group B, and 2 in Group C. There were 8 cases of post-PCI cardiogenic shock in Group A, 1 in Group B, and no such case in Group C. In Group A, hospital mortality was 6, 1 in Group B, and 0 in Group C. The results implied that administration of a combination of aspirin, ticagrelor, and tirofiban effectively reduced the occurrence of serious complications following percutaneous coronary intervention. There was an increased risk of bleeding due to the therapy. Therefore, close clinical monitoring was required.